Today we're going to demonstrate our technique for posterior labral repair. In this patient, he had a number of posterior dislocations with continued dysfunction and inability to do his normal activities without posterior dislocations. You can see here there's been significant damage to the labrum as well as the posterior chondral surface. First, a debridement is performed of the labrum and the posterior glenoid. This is taken down to improve healing and to allow advancement of the posterior labrum. A percutaneous posterior lateral portal is placed in addition to the standard anterior and posterior cannulas, and we're viewing anterior superiorly. This is a small percutaneous metal reusable cannula. We are here close to the inferior portion of the glenoid. We will place a Arthrex suture tack, which is biocomposite, loaded with suture tape in. In this lateral position, we're able to obtain an excellent inferior position on the glenoid. Following this, we use a Limbitech passer to imbricate the inferior glenohumeral ligament and further tighten up the posterior labrum and posterior structures. A first pass has been obtained, a second pass is obtained so we can have a horizontal mattress fixation inferiorly. Again, this is the most important suture, and a horizontal mattress is done in this situation for me. Sequential half hitches are performed. As you can see here, we already had around half a centimeter of advancement and excellent fixation at this area. After these sequential half hitches, we've cut the suture, and again we perform a second suture tack horizontal mattress in this patient given the significant mobility and the need to further constrain the posterior portion of the shoulder. As you can see, our second fiber tack has been placed, as well as a third push lock in an interrupted fashion. This tightens down the entire construct. Following this, a fourth push lock is placed. This is drilled. Following this, we use a crescent passer here to pass through the labrum. It's pulled out the front. A shuttling suture is placed, and the labral tape is passed. We engage the push lock with the labral tape into the glenoid for our final fixation. Finally, we probe the entire posterior labrum. We demonstrate intact labral repair and adequate capsular plication. Finally, given this a posterior instability, we close the posterior capsule with a blind outside-in approach. We pass first with a crescent passer, pulling the suture, our PDS suture, out of the front. Following this, we pull out of the cannula and out of the capsule. We keep the cannula between the muscle and the capsule. As you can see here, we are pulling the passer. The cannula is right outside the capsule, and we come in with a bird beak and retrieve the PDS suture from the other side. And then we blindly tie the capsule back together in this inside-out fashion. Once this is closed, we cut it, and we've done our capsular plication without any further damage to the capsule. This completes the posterior labral repair.